Okay, sir. Hello, sir. Okay, sir. Okay. Good morning. എല്ലാവർക്കും കേൾക്കാൻ പറ്റുന്നുണ്ടോ?
കേൾക്കാം.
Okay. So my topic is trauma team. Okay. So objective under this is hello. Objectives are describe the configuration of a trauma team, identify the team leader's role and responsibilities, discuss the qualities of effective leadership, list the roles and responsibilities of team members, describe how a team can work effectively to deliver ATLS, describe best communication practices among team members, describe areas of potential conflict within a trauma team, and general principles of managing conflict. So first, introduction. In the dynamic and unique ED environment, complex trauma care requires strong interprofessional teamwork and resource management. Success requires well-coordinated ATLS trauma team. Team resource management is nothing but it is a set of strategies and plans for making the best use of available resources, information, equipment, and people. So clinically trained in ATLS, clinicians who trained in ATLS techniques can function with others to deliver excellent team care with a common goal. So we'll come to the trauma team configuration. The trauma team ideally are composed of a group of people who have no other commitment other than to receive trauma patients. A trauma team should minimum consist of a team leader who's a senior doctor experienced in trauma management, and second is airway manager referred to as Dr. A. He should be skilled in airway management. Next is airway assistant, then a second provider referred to as a Dr. B, then two nurses referred to as assistant A and assistant B. Now additional staff should include wherever possible, whenever required, a scribe or a coordinator, transporter, technicians, nursing assistants, radiology support, specialists, for example, neurosurgeon, orthopedic surgeon, vascular surgeon, etc. The team should have access to other areas of hospital, including CT scan, angio suites, operating rooms, and intensive care facilities. So this is the trauma team configuration and the minimum required team who should be included in the trauma team. So now we'll come to characteristics of a successful ATLS team. Successful and an effective trauma team requires a good leader with experience not just in managing clinical cases, but also in leading and directing the team. They require broad knowledge concerning how to handle a challenging situation and the ability to direct the team while making crucial decisions. They must be prepared to take ultimate responsibility for the team's actions. Team leaders and their team members share a common goal to strive for the best possible outcome for the patient. So these are the main characteristics for a successful ATLS team. So now, communication between the team leader and the other team members is vital and is a key factor for a successful trauma team. The team leader must then communicate to incoming team members and the roles they perform and what their contribution should be. That is, if a new team members come to the team, the TL should assign roles to them, and the TL is the one who decides what they are going to perform and what their contribution is going to be in the team. So ATLS gives team members a common language for understanding each other's action and thought processes, particularly while prioritizing interactions during the primary survey. Now, feedback after action, once we have performed, review or debriefing once the patient has been transferred to definitive care can be valuable in reinforcing effective team behavior and highlighting areas of excellence. So now roles and responsibility of a team leader. So basically we have told the characteristics which is required for a successful team, ATLS team, mainly we are stressing on to the team leader. He plays a vital role in a ATLS team. He is who decides the who should be included in the team and who will do what function, and he is responsible for the entire team's action. So now, roles and responsibilities of that person, that is team leader. So introduce the team and assign roles, we have already mentioned. Second thing would be identify the scribe, explain how the team will communicate and use timeouts, ensure that all team members adhere to universal precautions, ensure assistants are available to help the team members, prioritize patient management during the primary survey, order appropriate diagnostic intervention and clinical procedures, and ensure that they are carried out rapidly and accurately. Check results of investigations once performed. For example, if CT is taken, he is the one who reviews the report. Make sure relatives are aware of what is happening. Timely communication and intermittently the bystanders or the relatives should be given the information what is happening with the patient. Call additional specialist team members when needed, that I've already mentioned. For example, neurosurgery in case of any brain injury, and if there is any trauma, you can the other additional specialists include orthopedics, vascular surgeons, plastic surgeons, etc. Then arrange for definitive care and communication with receiving physician when appropriate. Check the documentation is inclusive. Debrief the team. So documentation is also very important. So team leader will take up the whole responsibility for the documentation. And once the primary survey is over, once the event is done, then the team leader should debrief the team. So these are the roles and responsibilities of a team leader in a trauma team. So now team leader briefing the trauma team, how it is. So introduce yourself and ensure all the team members know you are the team leader. Ask team members to introduce themselves to you and other members as they arrive. Otherwise, there will be a confusion who will be doing what function or what action in the team. Establish the skill levels of team members, especially their competency to perform practical procedures and assign roles appropriately. Establish the nurse assistants are familiar with the environment and particularly location of equipment. Allocate the role of scribe, a suitable member of the team, and ensure that the documentation is done properly and timely. Ensure the team members, if they are taking care and using universal precautions to appropriately protect themselves from infectious hazards. Explain the procedure for taking handover of the patient. Ensure that team members know how to communicate important positive and negative findings during the primary survey, especially when the patient's condition deteriorates. Emphasize that important information about the primary survey must be communicated directly to the team leader, that is to you. Give clear instructions for any life-saving procedure required during the primary survey and establish the priority of these procedures. Explain the timeouts occurs at approximately 2, 5, and 10 minutes. This gives the opportunity to review the condition of the patient and plan further resuscitation. Emphasize that team members who need additional support, equipment, drugs, or resources must communicate directly to the team leader. Greet any additional providers who arrive to assist the team, although their help may not immediately require. Assign roles and responsibilities when appropriate. For example, if neurological consultation may not be required during a primary survey, but may be necessary when deciding if a patient requires craniotomy or intracranial pressure monitoring, etc. So basically, here the team leader is the one who ensures that he should ensure that all the team members know that he is the team leader. Then he should make sure that all the team members introduce themselves and they all verbalize what they are going to do. And the third thing would be he is the one who should communicate with the bystanders. He is the one who should do the proper documentation. He should make sure that his team members all have used universal precaution to protect themselves, and he should take proper handover of the patient, and he should ensure that proper communication is done between the team members. And if any procedures is if any life-saving procedure is done, each and every team members should inform and should verbalize to the team leader, and they should make sure that team leader has listened or has uh, uh, if the instructions are very clear to the team leader. Okay, so these are the briefing methods and briefing the team leader's role during the briefing time in a trauma team. So the team leader is ultimately responsible for the team and its work. So what are the main responsibilities? So here's this include preparing the team, receiving the handover, directing the team, responding to information, debriefing the team, talking with the patient's family and friends. So first, receiving handover. Usually it is done between the pre-hospital care staff and the trauma team leader in the emergency department. So MIST is an excellent handover tool that can be used in the time-pressured environment to ensure safe transfer of information without loss of important details. We all know MIST is nothing but M for mechanism, I for injury sustained, S for signs, and T for treatment and travel. So with using this MIST MIST, we will receive the handover. This is done between the pre-hospital care staff and the trauma team leader, that is yourself. So taking handover from the pre-hospital team, ask for silence from the team, all the team members. Direct one person to speak at a time. Ensure that immediate life-saving procedure is not needed. For example, if there is an obstructed airway, you have to check if any immediate life-saving procedure is required or not. Then use tools such as MIST and AMPLE to ensure complete information is gathered or not. Focus on the ABCDE and establish when intervention has been performed and how the patient has responded. Make note of critical time intervals such as time for extrication and transport. Record contact information for the patient's family and friends. So basically, while taking handover, all the team members, they should be silent, and the handover is done between the team leader and the pre-hospital care staff. And once the handover is taken, you have during taking a handover, you have to see if there is any immediate life-saving procedure to be done or not. If it is so, that should be taken care first. Then you can proceed with the handover. And mainly the team leader should focus on ABCDE approach and establish an intervention. And you can perform intervention whenever required in each stage. That is airway. If anything is required, airway can be managed. Then you can go to the next part, D part. Then next you can go to the C part and D part, and stabilize each one and do the intervention whenever required. So second role is directing the team and responding to information. That is, team leader must maintain overall supervision at all the time and respond rapidly to information from the team. Team leader make decision regarding adjuncts primary survey, directs, reevaluates when appropriate, and determines how to respond to any unexpected complications. For example, if all vital or all key decision will be taken by the team leader. So if anything during the primary survey, all the information or everything should be informed to the TL, and ultimately TL is the one, that is team leader is the one who takes the ultimate decision. So debriefing the team. Next action of the team leader is debriefing the team. The team debriefing often offers an opportunity for team members to reflect on the care provided to the patient. It occurs immediately after the event, as I have already mentioned. Follow a recognized protocol that includes questions such as what went well, what could we have done differently, what have we learned for next time, are there any actions we need to take before next time. That is, if any changes can be made, can be rectified, or if something had gone wrong during this trauma code or during this teamwork, what can be done differently to make it better, or did we go did something go wrong, should we rectify something. All this all details of all this we get if we do a debriefing. So this is also a role of team leader. So next is talking with the patient's family and friends. This is a very vital and very important role. So communication skill is very important when it comes to a team leader. Team leader is responsible for communicating with the patient's family and friends about the patient's injury and immediate care. Team leader should ensure the communication lines with the relatives are maintained at all the time. And if DNR orders is there, or DNR, this orders should be discussed with the relatives properly. And all the discussion with the family and friends should be recorded for then and there for a future purpose. Now you can see the tips for communicating with the patient's family and friends. Try to find a quiet room, that is our briefing room, where everyone can be seated properly. Always have another staff members with you. If you have to leave suddenly, he or she can stay with the family. Introduce yourself and establish who the family member or friend are and what they know already. Reassure the family and friends that other team members are continuing or they are already taking care of the patient over there, and you have come to take more detail about the patient. Explain things very clearly and repeat the important facts. Allow time for questions and be honest if you do not know the answers. Do not offer false hopes to the patient's relatives. If appropriate, emphasize that the patient is not in pain or suffering. Be prepared for different action. Maybe anger can be there, frustrations can be there, guilt can be there. So be prepared for all that. Before leaving the family, explain what will happen next and when they will be updated and what is the plan of the patient. Okay, so these are the tips for communicating to the patient's bystander, that is with the patient's family or friends. Now, next role of the team leader is effective leadership. Strong leadership skill can enhance team performance and effectiveness even in challenging situations. Good leaders are acknowledged to be people who have a wide range of skills, personal qualities, organizational understanding, and a good communication skill. So qualities and behavior of an effective team leader, let's see, showing genuine concern, being accessible, enabling and encouraging changes, supporting a developmental culture, focusing on team effort, inspiring other team members, acting decisively, building a shared vision, networking, resolving complex problems, and facilitating change sensitively. Now, roles and responsibilities of a team members. Now, we have already mentioned the roles and responsibility of team leader. Now, the team members, they also have got important roles. It is important for ATLS team members to understand what an ATLS team does, the role of the team leader, role of team members, structure of a team approach, application of ATLS in the team, effective communication strategies, common pitfalls of a teamwork. So guidelines for ATLS team members include introduce by name and role on the team. They have to introduce their name and what are they going to do. For example, if they are standing on IV axis, they have to tell I'll be dealing with the IV axis. If they are put on the scribe side, they'll have to tell my name is so and so and I'll be taking care of scribe. Ask for assistance when required. When they have a difficulty situation, or if the team leader is assigning a team member a role and if he is incapable of performing that, he can always ask for assistance and he can be very open or honest with the team leader that he is not so confident about that role and he can ask for a change of role. Next, never argue about a clinical decision. Even if we have another opinion, never argue. Politely or calmly you can have a word with the team leader, and ultimately team leader is the one who decides about the clinical decisions. Calmly and reasonably voice your concern. And next is trust and respect the team leader and the other team members. trust is a very important and key. It plays a very key role in a team as a teamwork. And always remember, irrespective of the roles, you have to respect all your team members, include team members and team leader, and mutual respect is must to run a successive code. So now, responsibility of team members. First is nothing but preparing for the patient. Next would be receiving the handover, assisting and managing the patient, participating in the debriefing. So already handover will be received by the team leader. When team leader brief, or if when he tells the team members about the patient in brief, they are the receiving handover is initially taken by the team leader from the pre-hospital care. So while receiving the handover, all the team members are asked to be quiet and they have to listen to the details of the patient, and then during as well as during the debriefing time. That is, debriefing is always done after the events, that is after the primary survey and after the event, debriefing will be done. And during the debriefing, all the team members and team leader, everybody should be involved in this, so that if there is anything to be rectified, can be rectified, and so that you can rectify the mistakes for the when you run a next code. So these are the responsibility of the team members. Once again, I'll repeat: preparing for the patient, receiving the handover, assessing and managing the patient, and participating in the debriefing. Now, delivering ATLS within a team. So once the patient arrives in your AD, first thing what you have to do is you have to the team leader will have to activate a trauma team, and you have to announce a trauma code. The team leader receives the handover and ensures that all the information are transferred to the team members. And team leader should assign roles to the team members, and each one will introduce and they will repeat the roles assigned to them. Now let's see the criteria for trauma team. Category is mechanism of injury. The criteria, for example, fall more than 5 meters, high-speed motor vehicle accident, ejection from the vehicle, high-speed motor vehicle collision, pedestrian, bicycle, or motorcycle versus vehicle more than 30 km per hour, fatality in same vehicle. Now, specific injuries, that is injury to more than 2 body regions, penetrating injury to the head, neck, torso, or proximal limbs, then amputation, burns more than 50%, or 50% in case of adult, and 10% in case of children, or involving airway, or if there is any airway obstruction. Now, a physiological derangement, for example, if the vital signs like systolic less than 90 mmHg, pulse 130, if respiratory rate less than 10, or if it is more than 30, if GCS score is less than, if it is not normal, chest injuries in patients older than 70 years, pregnancy more than 24 weeks with torso injuries. Okay, this is the criteria for trauma team activation. So now, first, once the trauma team is activated, next thing would be airway control and restriction of cervical spine motion. Securing an airway is often the role of the airway manager. I have already told the team members which is required to form a team. So in that, Dr. A, he'll be a skilled person in the airway management. So he will take care, he will be securing the airway. Now, cervical spine injury, if it is suspected, the doctor will establish the airway while restricting the cervical spine motion. Now, if at any point the airway becomes difficult to establish, this Dr. A should inform the team leader immediately. So now, next part is B, that is breathing with ventilation. So the first responsibility of Dr. B is to quickly, first you have that Dr. B should assess the breathing and establish that ventilation is satisfactory or not. Dr. B reports his or her findings on examination to the team leader. If a patient has life-threatening chest injuries, Dr. B may be required to urgently perform a needle, finger, or tube thoracostomy, and this should be informed and communicated with the team leader properly. Next is circulation with hemorrhage control. So, if once the AB part is over, next we come to the circulation part. Third provider may be required to assess and assist with circulation. Areas of potential hemorrhage should be identified and intravenous access established with appropriate fluid resuscitation should be done. If a pelvic binder is required, that is if you are suspecting a hemorrhage, so whenever a pelvic binder is required for controlling the pelvic bleeding, 2 ATLS trained doctors may be needed to apply this. So now we have finished ABC part. Now we come to disability part. So disability will be taken care by the Dr. A itself, who will be on the airway. Before the Dr. A gives the drugs for the before the Dr. A plan for a definitive airway, and before the Dr. A gives drugs for this definitive airway, he should assess the patient's Glasgow Coma scale, and he should always assess the pupillary size and record them properly. Next step is exposure and environment. It is vital to fully expose the patient, cut off all the garments to fully expose the patient, and evaluate thoroughly, and all the details should be noted and should be documented properly. Obvious injuries should be reported to the team leader then and there. Following exposure, you can cover the patient with a warm blanket immediately to prevent the hypothermia. Now, record keeping. Record keeping is an important role, and in some jurisdictions, it is performed by either by a scribe person, that is TL can either assign the role to the scribe person, or if it is not present, TL himself is responsible for the whole documentation of the trauma code. So all the information should be appropriately documented. That is, it should be documented in the pattern, that is ABCDE, and even the minor details of the patient should be documented in the trauma sheet. Trauma sheet should be maintained in all trauma cases, and this is filled, or this is kept using the system, that is ABCD approach. Earlier, for our trauma cases, we had this trauma sheet. So it was very easy, and it was very easy to identify whatever has gone wrong. That is, for example, all the minor injuries, including abrasions, lacerations, contusion, everything will be documented in the trauma sheet. Personal details of the patient, that is patient's, for example, the hospital ID, name, age, ID marks, who has brought the patient to the hospital, and the details, the relationship of the person, etc. And if the patient is referred from any other hospital, details of that hospital, and all these details are maintained in the trauma sheet, and this should be this is sole responsibility of the team leader. Now next is ensuring effective team communication. Communication between team members and team leader should be direct and only two-way. The team member should relay information, and team leader should confirm that he or she heard and understood the information. Timeouts, I have already mentioned, 2, 5, and 10 minutes may allow for discussion or review of findings. All communication should take place at normal voice level. Communication should not become extended discussion over the patient. Hold discussion a short distance away from patient, especially when the patient is conscious. Now, managing conflicts. The trauma team should function as a cohesive unit that manages the patient to the best possible outcome. All team members should have the opportunity to voice suggestions about patient's management. Team leader has ultimate responsibility for patient's management. In case of a conflict, a senior clinician, such as a trauma medical director, should be involved, because he will know more about the hospital protocols, and he will know in detail about the rules and regulations of each of the hospital, because it will be different from institution to institution. In case of conflict, as I've already told, uh, first the team members should discuss with the team leader, and ultimately, if team leader also has a doubt, he should refer to the senior clinician, that is trauma medical director. When controversies do arise, they are dealt with professionally and calmly, if possible, away from the patient being resuscitated. Thank you.
Okay, Sona, this is very important topic as far as our day-to-day practice is concerned, and also maybe this may not be asked in exams, but practically why you want to prepare for a course. It is not only to pass exam; it is to gain the knowledge for your day-to-day practice and to practice the things more effectively and save life. And your presentation is covered very minute aspects of the trauma team and trauma team, what is trauma team, how it is to be composed, and what is trauma code, and what are the indications to call trauma code, and how the team leader should behave, how the team member should behave, how the communication should be. Everything is covered very well. And the most important thing, whatever the half an hour or more you talk about, is to be implemented in dicto, word to word, in our scenario. Then definitely it will save a lot of lives. I want to ask you practical questions. So anyway, so another presentation. This is a good presentation.
Thank you, sir.
Contented very well. Only suggestion, if you add few pictures also along with your slides, it will become it is a contented. Now it is a contented trait. If you add pictures or some videos and all, it will become a visual treat as well, and it will impress more. Otherwise, it is perfect. Content wise, perfect. Presentation wise, okay. It is good. Only thing like a slide, if you can do, then it will break that visual monotony. That is all.
Okay.
Okay, definitely, it is a extensive presentation. Even some pointer someday in the next month or more, we will do the same. We can do the same presentation for our entire raster group as well. It will be very useful in that sense. I would like to
Okay.
ask few questions from the group. Vernas, how many trauma code you attended after joining here? Vernas.
Yes, sir.
Yeah. So after joining here, now it is more than 6 months, I believe. Is it so?
Yes, sir.
So how many trauma code attended to you here?
Definitely more than 5, sir.
Okay, very good. Just I'm asking, five more than 5 trauma code you attended.
Yes.
Can you remember out of the 5 any one? Just I am sharing because this is all very practically important. May not be exam wise, may not be that much significance. Sometimes ask a short note or something like that, but still practically it is very important. Any one of them?
Yes, sir.
Uh, what was the case briefly? Can you tell?
So 150 something female, sir.
50-year-old female. Okay.
Not exactly 50, but 50s
No problem. No problem. No,
female,
no. I
sir.
am not exactly pinpointing. But I am trying to say like a few practical aspects.
Sir, it was a history of RTS, sir. Bike versus bike, sir.
Okay.
And the patient was the pillion rider, sir.
Okay.
And she had fallen down, and there was a laceration, huge laceration on the left side of her head, and also a huge laceration on the face, including an orbital injury, sir.
Okay. Okay.
And Dr. Bindya was also there for that RTS,
Okay.
sir. And for that patient, we had announced the trauma code, sir.
Okay. Yeah.
Mainly, she had head injury, sir.
Okay.
Then
Mainly
the patient
had head injury. Okay. Perfect.
Yes,
So looking at Sona's presentation.
Yes, sir.
Why? Because the first thing first thing happened will be called trauma code. Is it so?
Sir, actually, I couldn't presentation towards the end, sir. Patient and sir.
You were there in the attendance from the first slide itself. Something is okay. Fine. I have a request for all of you. Like all the topic that we are discussing here is so relevant in our day-to-day practice in your exam. And so, like, if you again the people who are preparing for this presentation, they are take lot of time to do that, and a faculty sitting there also spending lot of time for this. So idea is like it is make your ease and all this. That is something distressing for me. Edwin, you listen that Sona's presentation. Is it so?
Yes, sir.
Did you receive the? Did you listen Sona's presentation?
Yes, sir.
Presentation listened. Okay. Did you see that the short history that Varna's given in this scenario? Did you receive understood that short history? There is a 50-year-old female, an RTA involved in bike versus is a pillion rider is brought here with a laceration face and orbital injury. This is the things that Varna's told. And she is also told like Bindya is also there in the case. And she also told she didn't hear that the first part, she didn't listen properly what Sona says. This is the contest. So tell me like what could be the indications for a trauma code for this case according to Sona's presentation. Sona's presentation is very scientifically authentical one. That content what she presented. Yeah, Edwin.
So trauma code activate usually when more than two system is involved in the patient. In this patient, mainly one has told there's a head trauma. So that is one system, and also lacerated wound is there, and also general surgery. They usually multiple disciplinary involvement is there. Usually activate trauma code. So in this case, after evaluating the patient only, we'll be activating the trauma code.
Okay, fine. Yeah, this is the short picture. What is what Verna's given. Suppose this patient is having only face laceration. Will you call trauma code?
it depends upon the whether the patient had a severe hemorrhage history. Then we'll be needing transfusion department, and if the patient is only presenting with the isolated non-active lacerated wound, I don't think we should activate trauma core.
Okay. My idea is like what I am trying to say, like Sona spoke about 30 minutes. To what level your attention span? That is I am testing. That is I am simply testing. Shaheen.
Sir, trauma code can be activated according to mechanism of injury.
Very good.
In this patient, if high speed.
So according to ATLS, what are the indication to activate a trauma core? That is a simple question I am asking.
The mechanism of injury.
Okay.
With different types like
okay.
High speed, high velocity, motor vehicle accident. Pinne falls. Falls more than 5 meters. Falls more than 5 meters. Then.
Okay, agreed. Yes. What else?
Then. Injuries based on injury sustained.
Injuries. Okay. Injury sustained.
Amputation.
Okay.
More than 2 body.
Okay. Good. Right. Last group.
If a vitals vegetable.
Okay. Vitals sharing. So at least like I am very happy to see that at least one person is listened very carefully about the presentation, and this is the problem of the people. Online class എല്ലാവരും ഓൺ ആക്കിയിട്ട് തരാ വരെ നടക്കും. അത് ഭയങ്കര ഡിസ്ട്രെസ്സിങ് ആണ്. പിന്നെ പ്രസന്റ് ചെയ്യുന്ന ആൾക്കാർ നിങ്ങൾ എന്താ ചെയ്യുന്നതെന്നുള്ളത് കാണാത്തത് കൊണ്ട് തെറ്റില്ല. പിന്നെ വി ആർ ഓൾ സ്പെൻഡിങ് ലോട്ട് ഓഫ് ടൈം ടു എംപവർ യു മോർ, ആൻഡ് that you have to understand all the presentations are happening for those students who are participating. All the faculties and all already learned this. We are not getting any additional benefit. This I am emphasizing. And some of the people, they are appearing only for that presentation. So not a very good trend. Okay. So you can remember this MAP indications. You can remember through map and map. It's a map indications to do code blue. M means mechanism of injury. Different mechanism of injury as Shaheen mentioned. A means anatomical pattern of the injury. Two organ. Then P is a physiological that systolic BP glow. അങ്ങനെയുള്ള കാര്യങ്ങളൊക്കെ പിന്നെ ഇതിപ്പോൾ ഈ രീതിയിൽ നമുക്ക് ഓർക്കാം. അപ്പോൾ whatever see like even the patient is ഒരു സിമ്പിൾ ഫേഷ്യൽ ലാസറേഷൻ മാത്രമേ ഉള്ളൂ, പക്ഷെ സ്റ്റിൽ ഇറ്റ് ഈസ് എ വെരി ഹൈ മെക്കാനിസം ഓഫ് ഇഞ്ചുറി. അതിൽ പറഞ്ഞ കാര്യങ്ങളാണെങ്കിൽ പോലും നമുക്ക് ട്രോമ കോഡ് വിളിക്കാൻ വേണമെങ്കിൽ. ദിസ് ഈസ് ഇൻ ഓർഡർ ടു അവോയ്ഡ് future like confusion. Okay, fine. Again back to Vernas presentation. Vernas boy salamata. Okay. How was that code run? It is like the or what are the best thing you noticed in that code, and what is the worst thing you noticed in that code?
So worst thing was actually code vilichu kayinte
best thing for you, the worst last always any kind of presentation any kind of communication. അതിലൊക്കെ തന്നെ നമ്മള് അല്ല, see, just listen me. How to communicate? Suppose like you are coming for or suppose you presented something, and if you are asked to comment about that, it should be always start with the best thing or the most appreciable thing should mention first. Then you can tell that the worst thing. This is the way you how to. The worst thing നിങ്ങൾ ആദ്യം the best thing എന്തായിരുന്നു, എങ്ങനെ how your team did that code. That's the best thing you noticed as a resident. Okay, I'm not saying like to criticize this like a hi-fi or the senior most persons, but exactly while you are attending that code, what is the best thing you notice, and what is your notion how it could have been done differently? This is the way. So these are the three component, at least three components should be your critics. One is what is the best thing, what is the worst thing, what additionally we can do, or what it could have been done differently. These are the things. Yes.
So best thing, as soon as the trauma code was announced, Dr. Bindya helped me more in setting the things, and all the staffs and all they became more alert, sir. And also from the blood bank, the person reached very fast. Like all this, Dr. Bindya was a very good leader. She knew what exactly to do, and given that there was a face laceration and she was quite an obese patient, she was ready. She had a difficult intubation in her mind and all that, sir. The worst thing was that usually when a trauma code was called, out of most of the trauma codes what I had seen, as soon as we used to call the trauma code, all the departments used to reach. But on that particular day, after we called the trauma code, even after like 5-6 minutes, nobody came. And then we had to go and call like each doctor on the phone, asking them to come.
Okay.
So I felt because of that, a lot of things were delayed.
Okay.
And I felt the better thing, and I think that could have been better, sir, because I felt like we had to call each and every person and ask them to come.
Okay, very good. Yeah, that is a very, very. So, what is your suggestion to improve that?
Sir, I mean, I'm not sure how it works in the other department. Let them know who should be arriving for the trauma code exactly. Because it was like when I called one person, they were like, "We are in the theater, please call the next person." So, some coordination over there.
Okay. So again, I'll back to one of the. Okay, Sona, you just listen Varna's that a practical scenario what Varna's brought about.
Yes, sir.
See, what is your comment on, or what is your suggestion according? Now you are the person in the group who prepared and extensively read about the trauma code system and how it should be run and how it should be activated, how to be implemented, how to be documented. Everything you brought about, I'm very impressed about that. So now you are the real master of this group. Presently 7 people or 8 people are there in the group. They are listening to the discussion. Now the Varnas, okay, definitely we will appreciate this Bindya for the wonderful leadership, and Varnas is affirmed that yes, here it is the taking entire code, trauma code minus Bindya is -3 or -4 according to the Varnas. I believe so. Okay, but the rest of the thing, no one is there. These are the way, like she told, and a lot of issues are there. and how it could have been done differently. At that question, Varnas is not experienced enough to tell. That is according to her. Then,
Okay. Sir,
then add your comment or
yeah.
how you
Thing is,
comprehend all the scenario.
thing is, in our hospital we have this. If code blue is there, we have post code blue meeting. Likewise, debriefing of the team doesn't happen here, so that should be implemented according to me. So the team debriefing should be done, and each and every team should be given opportunity to talk and to tell about their experience, and if something is lacking, and to talk about the success, what was good, like Verna said, what good things happened in that team, and what things required to improve, and so that we can identify that and improve in the future performance or next code. So that should be done. That is my opinion. I think I have already discussed. Few questions should always be taken care. Like what went well, like what could we have done differently, like what did we learn from this, and what can be done for the next time, and if there is anything action lacking from our side, so that we can do for the next time. Such questions should always be kept in the team leader's mind, and team leader should be debriefing the team, and each and every team member should be given opportunity to talk from their side too.
Okay.
And if something has to be done, this should be spoken to the higher authority, that is department head or something, and department head can communicate to the other departments and rectify the miscommunication. Such mistakes and all can be rectified.
Okay. I think that is a brilliant observation, Sona. I well appreciated that. And the very interesting thing, yes, I agree with. Now I incidentally and randomly selected one case, and incidentally Varnas bring about one case. And as Varnas mentioned, one gross issue happened here. Okay, before that, we will also listen what that team leader, those time Bindya was the team leader. What is the Bindya's version on this? Whatever
Okay.
is
Hello.
Yeah.
It was actually almost about like everything was covered by Verna only, but the worst thing that happened was the other departments. Nobody came within like after 10 minutes only. We was just trying to call up the plastic surgery people to attend. So when they when we come, they were asking like they told that like one of them told that they are not like available. They're in the OT, so just call someone like that. So nobody else from the general surgery or orthopedics, nobody came for that like event within like 15 minutes they reached out there. So that was a big issue that happened there. The initial part and all, it was almost gone well.
So I appreciated that all leadership of Bindya and Varna's people did beautifully that code. But the
thing was it was not a simple laceration over the face there. It was almost crushed, like above
okay,
the upper lip.
no problem. And I am not talking about the injury. Just I am dissecting how the things you should manage, because you people. That is, I agree. Well appreciated that all you managed and you. According to me, now I am listening Varnas, listening Bindya, listening Zona, and listening Shaheen and Edwin. So for me, yes, it is okay. We have a system is placed. And if the system is working, definitely Bindya is a third-year resident, and she have a limitation to call the big people and to call them and to or this thing. This is a big issue. But I am one very sad point I want to bring at this contest is today. When this code happened, approximately, anyone of when it was happened?
It's almost like 2 weeks back.
Okay, perfect. 2 weeks back. 2 weeks back, something happened. See, what I want from you people is, this is something lacking in our department. That is a reason why if it is something happened in your shift, something is wrongly happened, or it is deviated from the protocol, you should bring to our level. Now I incidentally hook up one case. Incidentally, this is bring about, that is something like a God signature. See here, for your information, lot of competition, lot of hitching, hooking, it's all happened between the trauma team. So a trauma code called no one is turned out means it is an unpardonable mistake. And this may not be sorted out with Bindya's level. Even sometimes it may not be sorted out up to Vinith level or your faculty level. So every day, if you during your shift, if you fell an issue, that an issue, whatever, if it is a good thing, if you do a very wonderful case, a manageable case, that should bring about our the forum in front of, at least like in a at least in a WhatsApp form. I want like personally to communicate all this, because other WhatsApp sometimes I may see or may not be see. This is something a gross issue. It has happened here, and this is the team members not brought about till today. Incidentally, I hooked up. That is the all points core to me, because this is something I have to take it in a very higher level. You people are like just superficially coming and doing it is not there. Why you so in any of the area, if it is in acute care 1, acute care 2, in the main area, it's all there. You should bring up to the department head. Okay, if you are when some when concerned to this is definitely to come to my in my table. No doubt about that. The other team members and all icon, because this is one point something happened. I am the person to answer. More than that, the people, many of the people are coming here. Is also like they believe like we are the senior people here. This is all the reason. So a trauma code system, Bindya minus trauma code means -5 means it is a gross issue. So definitely, and also it should be documented also in the trauma code. I will check that whether it is documented or not. So this is the thing I want to tell. So Bindya was the faculty on duty, or some other faculty is there along with you?
No, sir, I was the faculty.
Okay, but definitely Bindya. Another thing, don't. Another thing I want to tell you, like I am putting Sona, Samik, and Bindya and all in the faculty pool on duty. That means it is not simply covering up this. I want to give you some experience how you are managing in the top line. On the top of this, if you have some problem, definitely, or whatever the good thing you did, whatever the bad thing you did, that is I am the person fully responsible for that. So this is the one lacune, that is major lacune I want to tell. Not only why I am telling this is the other juniors and all listening here, they should also know while you are taking a duty in the fact, this is something you have to bring to us. This I have sometimes your problem is very minimal, we will address. I will tell this is the way to do, this is not the way to do. Even if something like something wrongly happened, a wrong drunk happened, it's all you have to bring up to closely with us, and then only we can correct this issue. So this is the very important administrative part. So your trauma code, like assessment part, management part, clinical assessment part, then operational part, and also administrative part, then communication part. There are multiple components, at least 10 components of the trauma code will be there. So here it is while you are taking a team leader, and while you are sitting as a faculty level duty, yes, this is whatever I am talking about. It is not only for you, for the other faculties also. Here like currently when taking the faculty full, we have Vineet and Abhiram has got some experience what is happening here. Okay, definitely Sajana is working 3 years. She has also know what is here, and all others are very new here. So so what I want to do, like this kind of feedback should come. Otherwise, it will leave there unattended, or then this will repeat again. What will happen? See, like over a period of 2 year or more, sometimes the Edwin, other people, Shahim, Edwin, Nadia, Vernas, all these people become the faculty level. So they will think that what we did is the correct, and they will follow that wrong thing. And this in the life, generally what the people will follow that wrong things. So that is the reason why you have to correct it. Yes. So I think that is more than enough for today's. Yeah. So,
ഒരു ഇഷ്യൂ പറയാനുണ്ടായിരുന്നു ലാസ്റ്റ് ഒരു 3 days ago 26th ഈവനിങ് ഡ്യൂട്ടിക്ക്
Nadia speaking. Nadia speaking.
ഡോക്ടർ അനു ഡ്യൂട്ടിയിൽ ഉണ്ടായിരുന്ന ദിവസം സർ അന്ന് ഇങ്ങനെ കുറച്ച് ഇഷ്യൂസ് ഉണ്ടായിരുന്നു. ബിക്കോസ് അന്നൊരു ട്രോമ കോഡ് വിളിച്ചിട്ടുണ്ടായിരുന്നു. ഒരു ബ്രദർ ആൻഡ് സിസ്റ്റർ ഒരു 2-wheeler ആക്സിഡന്റ്. സോ അതില് ഈ ബ്രദറിന്റെ ഫാസ്റ്റ് ചെയ്തപ്പോ വി ഹാഡ് സം കൺഫ്യൂഷൻ. അപ്പൊ അത് കൺഫേം ചെയ്യാൻ എനിക്കും ഐ വാസ് നോട്ട് ഷുവർ അബൌട്ട് ദാറ്റ്. ആൻഡ് സർജറി സൈഡിൽ ഫസ്റ്റ് ഇയർ റെസിഡന്റാ വന്നിട്ടുണ്ടായിരുന്നു. സോ ഹി വാസ് ഓൾസോ നോട്ട് ഷുവർ. അപ്പൊ ഞങ്ങൾക്ക് കൺസൾട്ടൻസ് ആയിട്ട് ഡോക്ടർ അനു മാത്രമേ ഉണ്ടായിരുന്നുള്ളൂ. സോ ഹി വാസ് ലൈക്ക് ഞാൻ അനസ്തേഷ്യ ഐ എം നോട്ട് വെൽ വേഴ്സ്ഡ് വിത്ത് ഫാസ്റ്റ്. സോ ഞങ്ങൾക്ക് MDICU ഡോക്ടർ സമീഹിനെ വിളിച്ചിട്ട് ഹി ഹാഡ് ടു കം ആൻഡ് ഡു ദ ഫാസ്റ്റ്. അപ്പൊ അന്നങ്ങനെ ട്രോമ കോഡ് മാനേജ് ചെയ്യാൻ കുറച്ച് ബുദ്ധിമുട്ടുണ്ടായിരുന്നു സർ. ഓൾസോ അന്ന് നല്ല റഷുള്ള ദിവസമായിരുന്നു. സോ 2, 3, 4 ട്രോമ ഒരുമിച്ച് വന്നിട്ട് എല്ലാം കൂടെ അന്ന് ഇറ്റ് വാസ് എ വെരി ഡിഫിക്കൽട്ട് ഡ്യൂട്ടി ദാറ്റ് ഡേ. കൺസൾട്ടൻസ് ഇല്ലായിരുന്നതുകൊണ്ട് ഉണ്ടായിരുന്നു. ബട്ട് ഹി വാസ് നോട്ട് വെൽ വേഴ്സ്ഡ് വിത്ത് എമർജൻസി മാനേജ്മെന്റ്. ഹി കെപ്റ്റ് സേയിങ് ദാറ്റ്. So
okay, that I even understood. That situation I understood. That is the reason why immediately MOD call I asked to involve other people, from the surgical, medical, and other people is there. If it is some issue for another thing here, it is addressed. If you have some issue to sort it out fast, definitely Samik is the not person to call for. He is maybe already there on duty. And even if Sami he is coming, the next level, suppose fast is positive or negative, where the case will go next, or to whom you will call?
Such general surgery?
No, madam. Well, general surgery person will coming is part of general surgery person will come part of the what do you call the trauma code. I am specifically talking about the fast. Suppose you have a fast, no one is competent enough in your group to do the fast, number one. And if you, exactly, radiology is how far away from our department? How far away from our department? No, yeah, I'm very happy that Nadia, you bring about this situation. Those time your thinking was lot of cases, lot of issue. Your thinking was going this way. This is another titrated thinking. If like suppose you 3 people are there, if one, so those days your team, Nadia, the other thing, Anu and a few other people are there. So here it is a polytrauma case coming. Suppose if it is an airway issue, Anu will be very good enough to, about that part you will not worry about this trauma. So just I am telling how to titrate it up. Suppose it is a complicated medical case coming, suppose Anu tell I am not very good enough, so to whom you call in that level to help you? Suppose you people are, you suppose Nadia is also not very confident, so to whom you will call? So a medical case coming, so there is a myocardial infarction with shock and AF and all. If you have some issue to sort it out, or like you don't know whether it is a cardiac issue or it is a pulmonary issue, something is confusing in between. But Anu say, I'm an anesthesiologist, I am not very okay. So to whom this case to be, and this is a busy number of 10, 20 cases are there in the ED, to whom you can easily to escalate that case, or to call from some other department to whom you can call. Yeah. You can tell to whom, whatever, what you will do. Nadia. പറഞ്ഞോട് കൂടെ പോയോ? നമുക്ക് ഇത്ര സമയമല്ലോ, പെട്ടെന്ന് അല്ല നമ്മൾ എമർജൻസിയിൽ ഞാൻ അഗൈൻ ഐ ആം ഇൻകൾക്കേറ്റിംഗ് ദ തോട്ട്സ് ഓഫ് എമർജൻസി. ഈ എമർജൻസി എന്ന് പറയുമ്പോഴേ ഇത് ഈ ഒരു ഭാഗം ഞാൻ മാത്രമേ നോക്കുള്ളൂ, ആ ഭാഗം ഞാൻ നോക്കില്ല, അല്ലെങ്കിൽ ഇതിൽ അങ്ങനെ പറ്റില്ല. ഇത് നമ്മൾ എന്താണെന്ന് വെച്ചാൽ എമർജൻസി ഫിസിഷ്യൻ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഹീ ഈസ് ദ പേഴ്സൺ, ഹീ ഓർ ഷീ ഈസ് ദ പേഴ്സൺ ഹൂ take the opportunity to coordinate and make that most effective management and the resource mobilization. അതുകൊണ്ട് അതിൻ്റെ ഒരു ഭാഗമാണ് നമ്മൾ എമർജൻസിയുടെ ഒരു ഭാഗമാണ്. അപ്പൊ നമ്മളൊരു ഭാഗത്ത് സ്റ്റക്ക് ആവുമ്പോൾ ഉടനെ ഈ എസ്കലേഷൻ തോട്ടാണ് നമ്മൾ ഈ 3 വർഷങ്ങളിൽ നമ്മൾ, അല്ലെങ്കിൽ വാട്ട് എവർ ദ ടൈം യു ആർ സ്പെൻഡിങ് ഹിയർ യു ആർ ലേണിംഗ്. അപ്പൊ ആരെയാണ് നിങ്ങൾക്ക് വിളിക്കാൻ പറ്റുക ഞാൻ ഈ പറഞ്ഞ കേസിലാണെങ്കിൽ?
കാർഡിയാക് ഇഷ്യൂസ്
അല്ല ഞാൻ പറഞ്ഞല്ലോ, ഇത് നമുക്ക് ഉറപ്പില്ല. പിന്നെ യു ആർ പ്രസന്റിങ് വിത്ത് കാർഡിയാക്, പക്ഷെ പൾമണറി എഡീമ ഉണ്ട്, പിന്നെ CKDന്റെ ഒരു പിന്നെ ഇഷ്യൂ ആ പേഷ്യന്റ് പറയുന്നുണ്ട്. അപ്പൊ ഇങ്ങനെയാണെങ്കിൽ ആരും വിളിക്കും? അതൊന്ന് നിങ്ങൾക്കത് കുറച്ചൊരു കൺഫ്യൂഷൻ ഇടാ. മാത്രമല്ല നിങ്ങൾക്ക് ഒറ്റയ്ക്ക് മാനേജ് ചെയ്യില്ല എന്നൊരു ആവശ്യം ഒരാളെ വിളിക്കണല്ലോ. ബിക്കോസ് അവേഴ്സ് ഈസ് എ മൾട്ടി സ്പെഷ്യാലിറ്റി ഹോസ്പിറ്റൽ, ഓൾ ബാക്കപ്പ് സ്പെഷ്യാലിറ്റീസ് ആർ ഹിയർ. അപ്പൊ ആരെ വിളിക്കും?
general medicine.
Yeah, definitely. അതിലെന്തത്ര ആലോചിക്കാനുള്ളത്? You can call a medical registrar who is 24 available, ask him to come and support that case. അപ്പോൾ ഇവിടുത്തെ രണ്ടാമത്തെ കേസിൽ ഇവിടെ നിങ്ങൾ ഒരു റിസോഴ്സ് മൊബിലൈസേഷൻ ആൻഡ് ഇൻഅപ്രോപ്രിയേറ്റ് യൂട്ടിലൈസേഷൻ ഓഫ് ദ, ഇതിങ്ങനെ നമ്മൾ വളഞ്ഞ് മോക്ക് പിടിക്കണം. നിങ്ങൾ വിചാരിക്കുന്നത് ഒരു എമർജൻസി ഫിസിഷ്യന് മാത്രമേ ഫാസ്റ്റ് ചെയ്യാൻ പറ്റുള്ളൂ എന്നുള്ളതാണ്. അങ്ങനെയല്ല. പിന്നെ മാത്രമല്ല, പിന്നെ someone I posted there in other area, നിങ്ങൾ ഇൻഡയറക്ട്ലി ഗോ ആൻഡ് കോൾ സമീഹിനെ അവിടെ നിന്ന് കൊണ്ടുവന്ന് ഇറക്കി ഇതൊക്കെ ചെയ്യുമ്പോൾ അതിൻ്റെ ഒന്നും ആവശ്യമില്ല. കാരണം 1 മിനിറ്റിൽ റേഡിയോളജിയുടെ PGനോട് എമർജൻസിയാണ് വന്നിട്ട്, അല്ലെങ്കിൽ റേഡിയോളജിയിലുള്ള ഒരാളോട് 24 hour റേഡിയോളജി സപ്പോർട്ട് ഉണ്ട്, അവരോട് വന്നിട്ട് നമ്മൾ ഈ ഫാസ്റ്റ് ഓൺ ചെയ്ത് തരണം, എന്തെങ്കിലും പ്രശ്നമുണ്ടോ എന്ന് നോക്കി തരണം, അല്ലെങ്കിൽ 5 കേസ് കിടക്കുന്നുണ്ടെങ്കിൽ ഈ 5 കേസിന് ഒന്ന് ഫാസ്റ്റ് ചെയ്ത് തരണം എന്നുള്ളത് പറയുകയാണ് വേണ്ടത്. ദാറ്റ് ഈസ് നമ്പർ 1. Number 2, I want to specifically tell to Edwin, Anjana, Shahim and Nadia. ജൂനിയർ ലെവലിൽ 3 ആളെ ക്ലാസ്സിൽ വന്നിട്ടുള്ളൂ. ബാക്കിയുള്ള ആളുകൾ അപ്പൊ നിങ്ങൾ പറയേണ്ടതെന്ന് വെച്ചാൽ നോർമൽ ആയിട്ടുള്ള എല്ലാ കേസുകളിലും ഫസ്റ്റ് ഓഫ് ഓൾ യു ഹാവ് ടു ഡു ഫാസ്റ്റ് ബൈ വിത്ത് യുവർ ഹാൻഡ്. അത് നിങ്ങൾ ചെയ്തിട്ട് നിങ്ങൾ പിന്നെ അസ്യൂം ചെയ്യുകയല്ല വേണ്ടത്. പിന്നെ യു ഹാവ് ടു ഷോ യുവർ സീനിയർ, ദിസ് ഇസ് ഐ ആം ഡൂയിങ് ദ ഫാസ്റ്റ്, ടെൽ മീ ദിസ് ഈസ് കറക്റ്റ് ഓർ നോട്ട്. And not only that, പോസിറ്റീവ് കേസ് ആണെങ്കിലും നെഗറ്റീവ് കേസ് ആണെങ്കിലും യു ഷുഡ്, സപ്പോസ് നിങ്ങൾക്ക് അതിന് കഴിയില്ലെങ്കിൽ യു ജസ്റ്റ് റെക്കോർഡ് ദാറ്റ് ഇമേജ് ഓർ ദിസ് ആൻഡ് ദെൻ ദ തിങ് യു ഹവ് ടു ഷോ അസ് ഇൻ ദ നെക്സ്റ്റ് ഡേ, അല്ലെങ്കിൽ whenever we are free. This is a way to learn it. നിങ്ങൾ സ്ക്രീൻഷോട്ട് എടുക്കില്ല, സ്ക്രീൻഷോട്ട് ആ കമ്പ്യൂട്ടറിൽ തന്നെ നമുക്ക്, ആ മെഷീനിൽ തന്നെ നമുക്ക് ലോഡ് ചെയ്യാൻ പറ്റും, സേവ് ചെയ്യാൻ പറ്റും, എന്നിട്ട് അത് നമുക്ക് പെൻ ഡ്രൈവിലേക്ക് എടുക്കാൻ കഴിയും. അപ്പോൾ ദിസ് ഈസ് സോ അനദർ തിങ് ഐ വിൽ ടെൽ യു, ഇഫ് യു ആർ പാസ് ഔട്ട് ഫോർ ദിസ് എക്സാം, ദിസ് ഈസ് വാട്ട് ഐ ആം ടെല്ലിങ് ഈസ് ട്രൂ ഫോർ സോണ, ബിന്ദ്യ ആൻഡ് അതർ സീനിയർ പീപ്പിൾ ആൾസോ. നിങ്ങൾ പറയുന്നതിന്റെ എല്ലാ ആൾക്കാർക്കും നിങ്ങൾ എഴുതി വെക്കും മോഡറേറ്റ് LV എന്നൊക്കെ പറയും, പക്ഷെ നോ വൺ ഈസ് സൂപ്പർവൈസിങ് ദാറ്റ്. അപ്പൊ നിങ്ങൾ ചെയ്ത ഫൈറ്റിംഗ് നിങ്ങൾ അതൊന്ന് പിന്നെ റെക്കോർഡ് ചെയ്തിട്ട് നമ്മളെ ആരെങ്കിലും കാണിക്കുകയാണെങ്കിൽ, നോട്ട് ഓൺലി ദാറ്റ്, സപ്പോസ് യു വാണ്ട് ആഫ്റ്റർ ഫിനിഷിംഗ് ദെയർ here and there, you people have the 6 months left behind. If you are completing your course and definitely you will working in a hospital where with an ultrasound machine is there, and if someone asks who is authorized you to do the ultrasound, and the question eppolum vara, you know, like that the PNDT Act and other nonsenses are happening in this country. This PNDT is something like a sword on your neck. So if you want to do show, not only this, even if you are planning for the UK appointment, I mean MRCM, and usually like if you go for FRCM further and all, again, like whatever the things you do, it should be document and you can keep it in your computer. And this you show to one of us, as we will show, and we will certify that, yes, this is the correct, this is the thing that we will tell, we are happy to do that. So this is the way like you have to carry forward your training program. Now you see like you have 8 faculty members in the department. If you shadow one person, this is enough. You because now the situation is different. It is more faculty members in the department than that residents. So appropriately use it everyone. And thank you, Nadia, for bringing about that issue. I am aware that there was some confusion. MOD called me, like then I asked, this call should be come from your side. We have the problem, sir, what you have to do. നിങ്ങളുടെ ഭാഗത്തു നിന്ന് വരേണ്ടതാണ്, അനുവിന്റെ ഭാഗത്തു നിന്ന് വരേണ്ടതാണ്. അപ്പൊ നമ്മൾ എനിക്ക് വരുന്ന കോള് സിഇഒന്റെ ഭാഗത്തു നിന്നാണ്, നിങ്ങളുടെ ഭാഗത്തു നിന്നല്ല. അവിടെയാണ് നമ്മളെ ഏറ്റവും വലിയ ഒരു ഡ്രോബാക്ക് വരുന്നത്. ഇപ്പൊ ഇവിടെ ഒരു പിന്നെ കഴിഞ്ഞ ദിവസം ബിന്ദിയ കാർഡിയാക് അറസ്റ്റ് അല്ല ഒരു പേഷ്യന്റ് ക്രാഷ് ചെയ്തിട്ട് ഇൻഡ്യൂബേറ്റ് ചെയ്യാൻ പോകുന്നു എന്നുള്ള കോള് എനിക്ക് ആദ്യമായിട്ട് വന്നത് പിന്നെ സിഇഒന്റെ അടുത്ത് നിന്നാണ്. സിഇഒയുടെ കോള് വന്നിട്ടാണ് ഞാൻ അങ്ങോട്ട് പോകുന്നത്. ദിസ് ഈസ് സംതിങ് എ ബിഗ് ഗ്യാപ്പ് ഈസ് എക്സിസ്റ്റിംഗ് ബിറ്റ്വീൻ മീ ആൻഡ് യു. ദിസ് യു ഹാവ് ടു കറക്റ്റ് ഇറ്റ്, അതർവൈസ് ഇറ്റ് വിൽ ബി എ ബിഗ് പ്രോബ്ലം. ഞാൻ പറഞ്ഞല്ലോ മാഡം, എന്തുകൊണ്ട് ഏതോ ഒരു ഷെറിൻ വിളിച്ചു കഴിഞ്ഞാൽ ഞാൻ എടുത്തോളുന്നുണ്ടോ? ഞാൻ ട്രാവലിംഗ് ഉണ്ടോ? ഒരു ഷെറിൻ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ പിന്നെ മൾട്ടിപ്പിൾ ആൾക്കാർ എന്നെ വിളിക്കുന്നതാണ്. If you have a important call, yes, you have to official നമ്മൾ acute care ടൂലെ ഫോണെന്നോ ഏതെങ്കിലും ഒരു ഫോണിൽ നിന്ന് വിളിച്ചു കഴിഞ്ഞാൽ sometimes I may not be able to do that. But any one of your group is calling, I will always take it. Or really put it like it is, I am in crisis, please come എന്നുള്ളത് നമ്മൾ പറയണം. അപ്പോൾ that is very important because unsupervised training sometimes may end up in a big disaster later, not now. Now you will cover here and there. Once when you are alone, this something every area, suppose it is someone is not peering, ഡെഫിനറ്റ്ലി ദിസ് പോസ്റ്റ് ഗ്രാജുവേറ്റ് കോംപ്ലക്സ് എന്ന് പറഞ്ഞൊരു സാധനമുണ്ട്. അതിലെന്താണെന്ന് വെച്ചാൽ നമ്മൾ ഒരു സെക്കൻഡ് ഇയർ ഫസ്റ്റ് ഇയറിൽ 6 മാസം കഴിയുമ്പോഴത്തേക്ക് വിചാരിക്കും നമുക്ക് എല്ലാ വിവരമായി എന്ന് വിചാരിക്കും. ഒരു 6 മാസം ഒരു ഡിപ്പാർട്ട്മെന്റിൽ വർക്ക് ചെയ്താൽ പിന്നെ അതിന്റെ മുകളിലുള്ള ആൾക്കാരോട് ഡിസ്കസ് ചെയ്യുന്നത് എന്തോ ഒരു മോശമാണ്. ഈ പിന്നെ കോംപ്ലക്സ് എല്ലാവർക്കും ഉണ്ട്. അതിനെ കൊണ്ടാണ് നിങ്ങളെ ജൂനിയർ മോസ്റ്റ് ആൾക്കാർ ഈ എഡ്വിൻ, അഞ്ജന, ഷഹീം, നാദിയ ഗ്രൂപ്പ്, പിന്നെ സോണ, പിന്നെ ബിന്ദിയ, സമീ ഗ്രൂപ്പിനോട് ഡിസ്കസ് ചെയ്യില്ല. ഈ ഗ്രൂപ്പ് ബിന്ദിയ, സോണ ഗ്രൂപ്പ് അവരുടെ ഡ്യൂട്ടിയിലുള്ള ആൾക്കാരോട്. അപ്പൊ അത് വളരെ പ്രൊആക്റ്റീവായിട്ട് യു ഹാവ് ടു ഡിസ്കസ് ആൻഡ് യുവർ തോട്ട്സ് ഷുഡ് ബി ബ്രിങ് അബൌട്ട്. And something is correctable, we can correct it. Something is not correctable, we will tell this is not the way. That will help you to out. ഇപ്പം ഞാനിപ്പോ ഇതിലെന്താണ് ചെയ്യേണ്ടതെന്ന് നാദിയ പറഞ്ഞപ്പോ അവർക്ക് അറിയാത്തതുകൊണ്ടാണ് അവർ റേഡിയോളജിസ്റ്റിനെ വിളിക്കാത്തത്. ഐ എം നോട്ട് ബ്ലെയിമിങ് യു, ഐ എം ടെല്ലിങ് ദിസ് ഈസ് ദ വേ. Radiology is just 100 meter, not 100 meter, 10-20 meter away from our department. There are also 24-hour people. If you have such an issue, you can utilize, because this is a multi-speciality hospital. Another thing, you have to escalate then and there, because our patients are coming to MIMS, means they are paying for everything. That is also another thing I always used to tell. You know, this starting from a simple cannula, a sticker on the cannula, it is costing to the patient. So think about it 3 times. If you are doing something, is it really required? If you are sending an investigation, think about, is investigation is essential? Is this investigation will change my management? This is the way, like the same thing I told you in one case for Shakim and Rashad, a trauma patient. They are enthusiastically tried for central vein access for the trauma management. Not much role for central access in those contexts. So because their faculties also have a thought, like if you want to administer blood, if you want to administer fluid fast, require a central line. It is not there. It is all old thought. it was a thought when I am doing my PG in 1989. In 2021 and 2020, peripheral line is more than enough to manage all these situations. But the situation is different with someone with coming with a multi-organ dysfunction, modes with a shock and all, where we have to do at least 3 drugs, 3 infusion we have to give, that we have to give to near to the heart, where the central line is indicated. Okay, perfect. Thank you for bringing about real practical points for the discussion. This is the way we have to moving forward our discussion.
ഒരു സാറ് പറഞ്ഞൊരു അസോസിയേറ്റഡ് ഒരു കാര്യം വേണം സാർ. സാറ് ഫാക്കൽറ്റി എണ്ണം കൂടി സാർ പറഞ്ഞു. പക്ഷെ എൻ്റെ ഒരു പേഴ്സണൽ എക്സ്പീരിയൻസ് ആണ്. ഞാൻ കുറച്ച് റെസിഡൻസിൽ ഷെയർ ചെയ്തിട്ടുണ്ട്. നമ്മൾ പുതിയ ഫാക്കൽറ്റി വരുമ്പോൾ, പുതിയെന്ന് വെച്ചാൽ ഇവിടെ മുമ്പ് വർക്ക് ചെയ്ത അലക്സാറെ പോലുള്ള ഫാക്കൽറ്റിക്കൊക്കെ അവിടുത്തെ സെറ്റിങ്സ് ഒരു പരിധി വരെ അറിയാം. പക്ഷെ ചില ഫാക്കൽറ്റി വരുമ്പോൾ അവർക്ക് ഭയങ്കര ന്യൂ ആണ്. അപ്പോൾ ഒരു ഹെക്റ്റിക് ആകുമ്പോൾ അതിന്റെ ഒരു സ്ട്രെസ് എനിക്ക് തോന്നുന്നു എനിക്കൊക്കെ വരാറുണ്ട് ഡ്യൂട്ടി ചെയ്യുമ്പോൾ. പ്രത്യേകിച്ച് ഒരു എക്സാമ്പിൾ പറഞ്ഞാൽ ഡോക്ടർ സിറിലൊക്കെ ഒരു ദിവസം ഡ്യൂട്ടി ചെയ്യാൻ വന്നായിരുന്നു. ഡോക്ടർ സിറിലൊക്കെ ഡ്യൂട്ടി ചെയ്യുമ്പോൾ ഡോക്ടർ സിറിൽ ഇവിടുത്തെ ആരെ വിളിക്കണമെന്നോ ഒന്നും അറിയില്ല. അത് അവരുടെ തെറ്റുമല്ല, അവർ ന്യൂ ആണ്. അപ്പൊ നമ്മളൊരു കേസ് കാണുമ്പോൾ നമ്മളിത് പ്ലാൻ ആക്കുമ്പോൾ അധികമായിട്ട് അവരുടെയും പ്ലാൻ ആക്കണം. അപ്പൊ നമ്മളൊരു ക്രാഷ് ആക്കുന്ന പോലെ ഹെക്റ്റിക് ആവുന്ന ദിവസങ്ങൾ സാർ.
Very well understood. That point is very well taken. പിന്നെ അങ്ങനെ ഒന്ന് രണ്ട് പിന്നെ ആളുകൾ വന്നു പെട്ടെന്ന് വെച്ചാൽ വി എൻഡ് അപ്പ് ഇൻ എ വെരി ഡിസാസ്റ്റർ സിറ്റുവേഷൻ. അതിനോടാണ് അത് വന്നു പെട്ടെന്ന്. ഡിസാസ്റ്റർ സിറ്റുവേഷൻ എന്ന് വെച്ചാൽ നിങ്ങളുടെ ഫാക്കൽറ്റിയിൽ 2 ആൾക്കാരൊക്കെ മറ്റേ കോവിഡ് ആയിട്ട് പെട്ടെന്ന് ഔട്ട് ആയതുകൊണ്ടാണ് നമുക്ക് അങ്ങനെ വേണ്ടി വന്നത്. I agree. Someone like even if it is a qualified person, someone with a Cyril, definitely Bindya, Sona and other people are better in that scenario. I fully agree. കാരണം someone is already worked for നമ്മൾ ഇതിൽ 2 വർഷം വർക്ക് ചെയ്ത ആൾക്കാർ തന്നെയാണ് പിന്നെ ഏറ്റവും ബെസ്റ്റ്. ഐ ഫുള്ളി അഗ്രി വിത്ത് യു. ചില സമയത്ത് പക്ഷെ നമ്മൾ വി ആർ ക്രാഷ്. അപ്പൊ ആരും ഇല്ലാത്തവര് കഴിഞ്ഞതിലേ നമുക്ക് ഈ കോവിഡ് സെനാറിയോയിൽ നിങ്ങളെ ആളുകൾ 1 by 1 ആയിട്ട് പോസിറ്റീവ് ആകുകയും അതിലിടയ്ക്ക് ചില ആൾക്കാർ പിന്നെ അൺഅവോയ്ഡബിൾ ലീവിലൊക്കെ വന്നുകൊണ്ടാണ് നമ്മൾ അങ്ങനെ ഒരു ക്രാഷിൽ പെട്ടത്. ആൻഡ് ഡെഫിനറ്റ്ലി പിന്നെ ആ ഒരു സമയത്ത് നമ്മൾ പറഞ്ഞ പോലെ നിങ്ങളെ കൂട്ടത്തിൽ പിന്നെ എഡ്വിനെ പോലെയുള്ള ആളുകളെയോ അല്ലെങ്കിൽ കുറച്ച് സീനിയർ ആൾക്കാരെ ഇടാൻ ചിലപ്പോൾ ശ്രമിക്കും. പക്ഷെ അതും ചില സമയത്ത് നടക്കാത്ത സിറ്റുവേഷൻ. അതാണ് ഇപ്പോൾ അനുവിന്റെ അന്ന് അനു ഇവിടത്തേക്ക് ഡ്യൂട്ടിക്ക് മാറുന്ന സമയത്ത് 3 പേരെ മറ്റോ 3 ഫാക്കൽറ്റി മറ്റോ എന്തോ ലീവ് ആവുക, അങ്ങനെ എന്തോ ഇഷ്യൂ ഉണ്ടായിരുന്നത്. 2 അപ്പൊ ഓക്കെ, that part definitely we will more careful about that when we are putting that such kind of people on duty. We will try to cover the other way. And ഞാനത് റിഷ്മയുടെ അടുത്ത് ഒന്നും കൂടെ പറയാൻ ഡ്യൂട്ടി. പിന്നെ ഇത് അൺഎക്സ്പെക്റ്റഡ് ആയിട്ട് വന്ന സാധനങ്ങളാണ്, ക്രൈസിസ് ആണ്. ഫോർ എഡ്വിൻ വെരി പോസിറ്റീവ്ലി ഞാൻ പറയേണ്ടതെന്ന് വെച്ചാൽ ഇത്തരം സാധനങ്ങൾ മേക്ക് ഇറ്റ് പിന്നെ വെരി പോസിറ്റീവ്ലി മേക്ക് ഇറ്റ് an opportunity to upgrade ourselves. പിന്നെ ഡെഫിനറ്റ്ലി നിങ്ങൾക്ക് ഏത് ഇഷ്യൂ ഉണ്ടെങ്കിലും യു ക്യാൻ കോൾ ഓഫ് അസ്, എനി ഓഫ് അസ്. നമ്മൾ വന്നിട്ട് വിൽ ഹെൽപ്പ് യു. ഡോണ്ട് തിങ്ക് ലൈക്ക് അത് എന്നെയോ വിനോദിനെ ഒന്നും വിളിക്കാൻ നിങ്ങൾ മടിക്കേണ്ട കാര്യമില്ല. നിങ്ങൾക്ക് പ്രോബ്ലം ഉണ്ടെങ്കിൽ അതിൽ പിന്നെ നമ്മൾ യൂഷ്വലി വിൽ സേ ലൈക്ക് നോ, തീരെ പറ്റുന്നില്ല എന്തെങ്കിലും നമ്മൾ വിൽ മേക്ക് ഇറ്റ് എൻ അറേഞ്ച്മെന്റ് ഫോർ ദാറ്റ്. താങ്ക് യു ഫോർ ബ്രിങ്ങിങ് അബൌട്ട്. എഡ്വിൻ, നാദിയ and like thank you for bringing about real ground reality. This is something very, very important. Okay, definitely whatever you are saying, this will be, I'll keep in mind and I will implement while doing the next duty. Try to implement. Sometimes we may be end up in a big trouble, but usually we'll try to. Okay, yeah, Bindya, go ahead your presentation.
Sir, audible alle?
Yeah, audible.
Yeah. Good morning, everyone. I'll be discussing about trauma triage and trauma score. So we'll start with trauma triaging. Okay. we'll start with the definition. So to define the triaging, so triage is the process of prioritizing patient treatment during mass casualty. So it is like it is defined as during a mass casualty. It is not done in it is not said that it is only done in mass casualty. Now each and every patient who comes to our department should be triaged to the appropriate area. So, altogether, what should be understood is a right patient to place at the right time with the right care provider is the basic triage concept. So, the origin of the triage word is actually derived from the French verb, which is the word is trier, and the trier meaning of the trier French verb is to sort out. So, that is the triage. So, the definition of triage is the triage. It's a process of prioritizing patient treatment during mass casualty. So there are some sentences that is principles of triage. This is the only thing which should be kept in mind while triaging the patient. So there are 5 to 8 points here as the principles of triage. So we'll start with the first one is recognize that rescuer safety is the first priority and do the most good for the most patients using available resources and make timely decisions and prepare for triage to occur at multiple levels and know and understand the resources which is available and plan and rehearse the responses with practical drills and determine triage category types in advance and triage is continuous at each level. So these points are well understood from the one sentence, but we are coming into the details. Like we'll shortly go through this. So the first thing is safety is the first priority. So whenever we are going into the scenario of whatever mass casualty or disaster, whatever it is, we as a rescuer we should make sure that our safety there should not be there is always a chance of second hit when there is an earthquake or any blast or anything, there is always a chance of second hit. So we have to make sure that we are safe before going to the scene directly. So that is the safety is the first priority. That is the first important principle of the triage. So another, do the most good for the most patients using available resources. So we have to make sure that we are carrying most of the patients, like if there is 100 or 200 or anything like that, we have to make sure that we'll care and we'll triage appropriately most of the patients. Like maximum number of the patients should be triaged to the appropriate area or the hospital. So another thing is make timely decisions. So we know that whenever a disaster or any mass casualty or multiple casualty comes, there will be very less time to make decisions. So that too from a very short or very little bit data or clinical examinations or anything. We have to make sure that we'll be doing a timely decisions. We'll be clinically evaluated. Quick evaluation should be there, and we'll be quickly prioritizing the patients and will be quickly triaging to the appropriate area. So that is the make timely decisions. So another one is triage occurs at multiple levels. So triage should be occur multiple levels means if there is a disaster or anything or any land issue, we have to make sure that we'll be triaging, or a triage-based person should be triaging a patient from the pre-hospital scenario. And once the patient reaches the hospital, we have to the triaging should occur in the hospital scenario. And if the patient requires any hospital treatment like operation or anything, surgical procedure is needed, we have to make sure that the triage occurs before the pre-operation. So that is the triage occurs at multiple levels. So that is a scene or site or outside the hospital or inside the hospital and pre-operative area. So another thing is know and understand the resources available. So anyone who is triaging the patient who should be well knowledgeable about the resources of the hospital or the department, and according to that only we'll triage the patient to the appropriate areas. So another thing is planning and rehearsal. So always if anything like disasters or anything happens, a quick reaction or response will be a kind of dilemma if there is no rehearsals or drills occur. That will be very difficult. So a proper rehearsals and drills should be very important for a mass casualty or disaster situation. So that was which happened in our we have done a crash plane crash or something, and it was like a drill. Mock drill was happened 2 years back in the same air. So it was so easier to bring up the patient to the to our hospital and to manage accordingly. So that was kind of well appreciated thing. So that is the importance of planning and rehearsal of a mass casualty or a triage. So another thing is determine triage category type. So we know that we are almost familiar with these like colors, red, yellow, and green. So this is actually there are some like this is according to the priority of the patient. We have to prioritize. So the red, yellow, green, and black. Along with that, we have some like blue, gray kind of things also there. We'll be coming into the details of that. So how do we triage or how do we prioritize the color? So if it is a red color or we are tagging the patient with a red tag, so that is the first priority or the most urgent priority, sorry, most urgent patient. So that will include life-threatening shock or hypoxia if present, or if it is there is like impending hypoxia or life-threatening shock or any airway issues, that should be first triaged into the red area or the first priority. So that is the red thing. And another one is yellow or the second priority or an urgent priority. So that is injuries have systemic implications or effects, but patients are not yet life-threatening, not yet in a life-threatening shock or hypoxia or any airway issue. So that there can be like, we can take a kind of like 30 or 45 minutes to manage the patient once we have done with the red patient. So that is the yellow. And another one is green, that is a third priority after the yellow, and that is non-urgent but who needs medical management. So they include injuries are localized without immediate systemic implication. With minimum of care, these patients generally are unlikely to deteriorate for several hours. And another one is black, it is like dead patient or deceased patient. So the last I have discussed with like it is a blue or gray color. They are like expectant patients. Expectant patients are like let's say that they are actually having more severe injury and unlikely to survive. So if they are going, if we are behind them, like behind the patient, like expectant patient, these patients will drain more resources and time, like that should be given for the red priority. So these patients are these patients are tagged as blue or gray. So that is the expectant patient. So another, the fourth principle is triage is continuous. So as I said, triage should be done in multiple levels, side, hospital or pre-hospital. Along with that, it should be like continuous. So if at all in the hospital, if the patient reaches in the hospital in a yellow priority, we have to repetitively assess the patient. If at all anything like if the patient deteriorates or anything happens, we have to up triage the patient, or if needed, we can retriage the patient. So usually the patient who needs retriaging is the expectant patient. So we once we have done with the almost done with the red priority patient and we have almost stabilized him, we can check whether the expectant patients, whether anything can be done for the patient. So example of expectant patient is a young patient with 9% of burn who may survive if we are giving more or the accurate burn center management for that patient. So who is young but 90% burns, who usually will not survive. If they are getting accurate or like top management from the appropriate hospital or hospital setting, they'll survive. So that is the expectant category who needs retriaging. So it is only once we have done with the red priority. So it is almost like these are the 5 or 8 principles of the triaging system. This is the only thing we should be remembered while doing the triaging. So we have recognized, so we have to make sure that our safety and do good for most of the patients, number of the patients, and make timely decisions and prepare triage to occur at multiple levels. And we have to be like very clear about the resources which is available, and we have to rehearse or we have to make plan. I mean, we like keep mock drills or like that, and we have to determine triage category types like red, yellow, what all things should be triaged or tagged as red, yellow, or green. And the triage should be continuous at each level. We have to repetitively assess the patient and retriage or up triage if needed. So that is about the triaging. So we'll come to the another important topic, that is trauma score systems. So the purpose of scoring systems, mainly the trauma scoring system, is purposes are mainly three things. So we have to appropriately triage or classify the patient, and to shift the patient appropriately to the department or the hospital according to the condition of the patient. So that is the one important thing that can be done from the trauma scoring system. So another one is to predict outcomes or mortality, or another last one is quality assurance. So these are the three things, main things which can be done from the trauma triaging system. So there are multiple scoring systems which is available based on the trauma or whatever, like any critical clinical issues or anything. They actually categorize into three groups. Anatomical scoring systems are there, physiological scoring systems are there, and combined scoring systems are there. The multiple, the number of scoring systems are there, but we will be emphasizing on the important scoring system, which is there in our ATLS 10th edition textbook. So anatomical scoring systems includes abbreviated injury scale or AIS score, and injury severity score or ISS, or on injury score or anatomical profile or AP, or penetrating abdominal trauma index, like that. So the important thing will be abbreviated injury scale and injury severity scale. Another one is physiological score. So they include Glasgow Coma Scale or GCS. We are most familiar with that, so I'm not going into the details of GCS. Another one is revised trauma score or RTS, and acute physiology and chronic health evaluation score. So these comes under the physiological scoring system. And combined scoring systems, injury severity score and trauma injury severity score, and a severity characterization of trauma or a score, or international classification of disease injury severity score or ICISS. So these are the scores, like anatomical, physiological, and combined scores. So come to the important scoring system. So abbreviated injury severity scoring systems, the anatomical scoring system, and it was initially used to score the soft tissue injuries, but nowadays it is widely due to grey injuries related to all types of blunt and penetrating traumas. So the scaling system or the scales or scores ranges from the 1 to 6. So 1 will be minor trauma and 6 will be unsurvivable trauma. So this is actually we have to score the each of the injury with the AIS score, and will be calculating as the ISS score. So this AIS score is the basis of the ISS score. So it is actually derived from, so AIS score usually calculated as any patient comes, we have to check whether there is head, neck trauma or facial trauma or chest trauma. There are 6 areas we are taking to calculate the AIS score. So with that, we will be calculating the IAS score. So it will be a bit confusing. So I'll come to that in detail, and how do we calculate the AIS score. So this is how do we calculate. So this is the example of abdominal, we are calculating head, and we are just categorizing, or we have about 6 areas to calculate the AIS scoring. So head and neck, face, chest, abdominal, limbs, and external or the unspecified areas are the external. So we have 6 areas. So in that, abdominal is one area. So here is the example of calculating AIS score of abdomen. So AIS score 1, 2, 3, 4, 5, 6 is there. 1 is for minor, and there is abdominal bruises or any abrasions only, we'll take it as a minor one, and 2, a small liver laceration is, we'll take it as AIS score of 2, and that is moderate, and 3, AIS score is serious, and if there is a liver laceration with more than 1 liter of blood loss, we have to take it as a serious issue and score under 3 of AIS. And 4 is severe if there is ruptured liver, and 5 is critical if there is liver laceration involving hepatic vessels, and 6 as maximum score if the Sewell's liver. So this is an example of AS scoring of the abdomen. So like that, if any injury over the chest, we have to calculate the AS score of chest. And if there is a facial injury, we have to calculate the AS score of face and limbs. If any, we have to go for AS score of limbs, like that. We have to calculate all the AS scores. We'll calculate on the ISS. So ISS score is the ultimate, like last confirmatory scoring system, like as a basis of S score. So injurity, so we have calculated the AIS score of the each and every body part. Say this face, or we'll take it as a face. If there is injuries over the face, we'll take it as face. I mean, A score of face and abdomen and chest. So how the ISS score is calculated from the AIS, or abbreviated injury scale. ISS from the AS. So ISS is mainly sum of squares for the highest AS grades in the 3 most severely injured ISS body areas. So here we have multiple areas like face. If there is face injury, we'll take IS score of face, and chest AS score of face, and abdomen will take the AS score of abdomen and limbs along with that. So we'll calculate the AS score, and we'll take the higher grades of the AS score, higher grades of the AS score, and we'll take a square root of 3 higher AS scores from the patient. So we'll add up 3 of them, and we'll calculate the ISS score. So that is 1 to 7. Usually it comes from 1 to 75. If the ISS score of the patient from the AS score, if it is less than 50, usually indicates there is a mild injury. And if it is 15 to 50, it is almost moderate injury. If it is more than 70, if it is more than 50 or 75, it's usually kind of unsurvivable injuries. So that is about the ISS score. So here you can very well understand that how the ISS score is calculated. So we have taken the head area. There is a minimal cerebral contusion, so AS score is 3. And face, there is no injury, 0. Chest, there is frail chest, 4. Score is 4. And abdomen, there is minor contusion or liver laceration, so it is almost like 2 and 5. In extremity, there is a fracture, 3. And external injury, there is no injury in the unspecified or external area, so that is 3. So we have almost calculated 1, 2, 3, 4 areas of AS score. But the higher grades are like 3, 2 and 5 over the abdomen and flail chest. So we'll calculate all, we'll square the 3, so it is 9, and 64 is 60, and 2 and 5, it is 25. So we will add up, and we got a score of 50. So score the patient as 50 of ISS score. So that is. So ISS tends to underestimate the injury in penetrating trauma, because injury in the same body region are not exposed. So if you are getting multiple injuries or similar moderate or severe injuries of the abdomen itself, 1 or 2 injuries are there, ISS score usually won't calculate like those 2 together. They'll only pick up 1 injury and calculate the scoring. So there is a lacuna in that. So we have just revised that. We have been a new injury severity score that includes the sum of all squares of most severely injured areas just regarding the body region. If there is multiple injuries over the abdomen, we'll take it as like 2, and we'll add up in with the score, and we'll calculate the NISS score. So that is about the anatomical scoring system. So we'll come to physiological scoring system. So initially we have scored, or we have calculated the trauma scores with the based on 5 variables like GCS, respiratory rate, respiratory effort, or systolic blood pressure, or capillary refill time. So it was almost actually the values ranged from 1 to 16. But there was some lacuna in that, some dilemma happened in that. So we have just revised the trauma score in 1989. We have just changed it as an RTS, or revised trauma score. So here there is values are ranges from 0 to 4, and the variables included are GCS, systolic blood pressure, and respiratory rate. So we all know that how the GCS scores is calculated, and This is how the RTS score is calculated. So GCS, there are 1, 2, 0, 4 categories. Categories, scoring systems as RTS, and SBP again there is 0 to 4, and respiratory rate again there is 0 to 4. So if the GCS is 13 to 15 and the systolic blood pressure is more than 89 and the rate is 10 to 29, we have to take it as a 4th category. And like that we'll calculate all the, like it is like seen in the table, 9 to 12 of GCS, 76 to 89 systolic blood pressure, rate of more than 29, RTS is 3, and like that we are just calculating like up to the 0. And if the GCS is 3 and BP is 0 and respiratory rate is 0, it should be the RTS value will be 0. So usually if if there is higher score, so what is RTS says that if there is higher score, there is a higher probability of survival. The mortality is very less. So if the patient is having a less than 4 RTS score, the patient should get like appropriate care and should be transferred to a trauma center. So that is about the revised trauma score. So as we know that the pediatric patient is not a young adult, so we have to like make something else for these patients, or we have to score according to the different scoring systems for the pediatrics. So the pediatric trauma score, we have 6 variables. So this is for pediatric patients. So 6 variables are there. We have to take the weight of the child and systolic blood pressure again, and the level of consciousness, and the presence of fracture, and the presence of open wound, and state of the airway. So how is it calculated? So we have to calculate. So this is the pediatric trauma scoring system. So weight, if it is more than 20, the score will be +2, and airway is normal, and systolic blood pressure is more than 90, and level of consciousness, if the child is awake, and fractured, there is no fractures, and cutaneous, if there is no visible injuries, will take it a score of +2. And if the patient is having a 10 to 20 of kilogram, and airway, there is oral, nasal, or airway, like we are just kept our oxygen via face mask or nasal prongs or like that, and the systolic blood pressure is kind of 50 to 90, and level of consciousness is obtunded or loss of any loss of consciousness if there is fracture, single or closed fracture, and if there is cutaneous contusion or abrasion or anything, we'll take it as score of +1. If the child is less than 10 kg of weight, or intubated, or any surgical airway has put, or systolic blood pressure is less than 50, or the child is in coma, or the fracture, if there is open or multiple fractures, or if there is any tissue load and short injuries or any penetrating trauma, we have to take a score of -1. So this is how do we calculate the score, like pediatric trauma scoring. If the scoring is less than 80, so this is actually the scoring system is usually correlates with the injury severity, mortality, resource utilization, and transport to the pediatric trauma center. So if the patient's pediatric trauma scoring system or the score is less than 80, the child should be triaged or transferred to a pediatric trauma center. So how is the, like if the child is having 9 to 12, the score is 9 to 12, it is usually a minor trauma. And if it is 6 to 8, there is a, like it is potential to have a life-threatening condition, to result a life-threatening condition. Or if it is 0 to 6 scoring, that is life-threatening. Or if it is less than 0, that. So this is how the pediatric trauma score is done. So another one is, the last one is the ABC score. So this is usually commonly used in trauma scenarios to like decide upon the transfusion or the NACID transfusion of the patient during trauma scenarios. So so that is AC score. There are 4 data points included under this. So we have penetrating trauma mechanism, and SB or systolic blood pressure is less than 90, and heart rate of more than 120, and if there is a positive pulse. Each of these variables are getting 1 point each. So maximum score will be 4, and if the patient is having 2 or greater score, we have to be ready with to start the massive transfusion. So that is the ABC score for transfusion. So another one is again in the severe hemorrhage to decide upon the transfusion or massive transfusion of the patient. So that is TASH score, or the trauma associated severe hemorrhage score. So these include, variables comes under the TASH score are systolic blood pressure, hemoglobin, fast, presence of long bone or pelvic fracture, heart rate, and base excess or base deficit, and gender of patient. So how do we calculate the TASH score is clearly seen in this table. So if the patient is a male, we'll score as 1. And if the hemoglobin is less than 7, that is 8, the score is will score as 8. And base excess, if it is less than -10, it's 4. And systolic blood pressure is less than 100, we'll make it as a 4 score. And heart rate, if it's more than 120, it's 2. Positive fast, yes or no. Yes if it is yes, 3, and no, 0. And unstable pelvic fracture, if it is yes, 4, it's given 6, and if there's no pelvic fractures, it's given 0. And open or dislocated femur fractures are there. If it is yes, we'll give 3, and if no, 0. So we'll calculate, and it varies like if the score is around 60, so there is a 50% probability of ending up in a massive transfusion for this patient. So if it is more than 27 the score is more than 27, there should be 100% probable, 100% of chance, 100% chance for getting a massive transfusion for patient. So that is about TASH score. So another last one is McLaughlin score that has got, again, is for massive transfusion. There are 4 variables. We have heart rate more than 105, systolic blood pressure more than 110, less than 1, and PS less than 7.25, and hematocrit less than 32%. So if there is each variable present indicates, if any of these variables present, it indicates there is 20% likelihood of getting massive transfusion. If all the variables, each and every, like all the 4 variables are present, there is a chance of getting 80% chance of the patient end up in massive transfusion. So that is the problem.
Okay, Bindya, that is highly informative, very useful presentation, and this is almost everything you covered here. Maybe we will also start practicing this scoring system in our ED. Then only like we will remember every day. Definitely for initial and second level triage, you can use RTS, revised trauma score, whether to predict the mortality, and also we can add that T score or something like that. We can add for further classification. Definitely, someone with more blood loss and all, we can apply like the TASH score or the what is that? McLaughlin. How will you pronounce that? McLaughlin. How will you pronounce that score?
McLaughlin.
Okay. One of them we can also, because I am preparing for the new trauma sheet based on the ATLS. So we will also, you need not worry about the calculate and all. While coming to the new trauma sheet, just you enter the value, automatically the scoring system will come. Something that I am designing in that way. What all topic is a very good presentation. It is something very important. You spend a lot of time, very comprehend, and it is covered almost everything. High quality presentation. What about any other presentation pending here? Nadia, and then another presentation, Nadia, or a confusion exists in the session തുടങ്ങാനുണ്ടായതുകൊണ്ടേ
എഡ്വിന്റെയും എന്റെയും വേർണസിന്റെയും 3 presentations.
അപ്പൊ ഈ 3 presentation എന്തായാലും ഇന്ന് കവർ ആവില്ല. So this presentation plus few of the other left out presentations. അതായത് അവന്തിക ജോണിന്റെ കുറെ പ്രസന്റേഷൻ ലെഫ്റ്റ് ഔട്ട് ചെയ്തിട്ടുണ്ട്. ജോൺ പിന്നെ ഇന്ന് കയറിയിട്ടുമില്ല. ജോണിന്റെ പ്രസന്റേഷൻ ലെഫ്റ്റ് ഔട്ട് ചെയ്തിട്ടുണ്ട്. That we will do another day, either Sunday or some other day.
Okay, sir.
So for the time being, we will stop now because that group academic program is to be started another 5-10 minutes.
Okay.
So thank you for that day. So all two your presentations, both two presentations are very useful and very good and very informative also.